We're ready to go. We're ready to go. Sorry for the delay.
That's all right. I think we're ready to go as well. So good morning, everyone. I will call to order the State Board of Health meeting for Thursday, September the 3rd, 2020. And I will ask our Vice Chair, Linda Hines, to lead us in the Pledge of Allegiance.
Good morning, everyone. Please join me in signing the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America
and to the republic for which it stands, one nation, under God,
indivisible, with liberty and justice for all.
With liberty and justice for all. That was surprisingly difficult. Thank you, Linda.
Yes.
Before we do our introductions, I will ask that we take a moment of silence in remembrance of our former board member and long-term board chair, Bruce Edwards, who passed away this past week. We will be doing a resolution for Bruce at the next meeting, but please join me in a moment of silent reflection. Thank you. Bruce was an incredible man, and we are all the better for having known him. So if we could just go around quickly and do introductions. I will say it's a little bit difficult looking at the screen the way that I am, so if you don't mind, I'll call on you and you can introduce yourself and what area you represent. Linda, you be first.
Good morning. I'm Linda Hines. I'm representing Managed Care Health Insurance Plans.
Thank you. Patricia?
I'm Patricia Kinzer, and I'm representing nursing.
Wendy.
Wendy Klein, representing Medical Society of Virginia.
Lisa?
I'm Lisa Harrison. I'm a consumer member of the board.
Anna?
Anna Jen, represent Public Environmental Health.
Benita? Benita, are you there? All right, we'll go.
Can you hear me?
I can now.
Can you hear me?
Kind
Oh,
of.
shoot.
We'll come back to you.
Can
Yes,
you hear me? Okay, good morning.
Yeah.
I'm Benita Miller, and I represent the Virginia Dental Association.
Thank you. Gary.
Gary Kreitzer, representing Emergency Medical Services.
Thanks, Gary. Good morning. Holly. Good morning.
Good morning, Holly Puris, representing Medical Society of Virginia.
Thank you, Jim. Edmondson. Jim, you're muted. Can you put your hand on the space bar? Still muted. Hold down the space bar. There you go.
All right. I thought I'd done that a minute ago. I'm Jim Hedvinson. I represent the corporate purchasers of healthcare.
Thank you. Jim Schuler, good morning.
Good morning. Jim Schuler, representing the Virginia Veterinary Medical Association.
Great. Mary Margaret.
Mary Margaret Whipple, representing the hospital industry.
Thank you. Stacy.
Hey, good morning. Stacy Swartz, representing the Virginia Pharmacists Association.
Norm.
Norm Oliver, State Health Commissioner.
And Polly. If you're on my screen, I'm asking you to introduce yourself. It's too hard to do it in any other way.
Good morning. My name is Polly Rabel, and I am with the Virginia Hospital and Healthcare Association.
Great. Robin. Good morning.
Good morning. Hi, I'm Robin Kirsten-Downs, the Attorney General Counsel to the State Department of Health.
Thank you. Lori Orlano, Dr. Forlano.
Hi there, this is Lori Forlano, Deputy Commissioner of Population Health at PDH.
All right, and I think that I've gotten everybody except all the staff in the Madison room, and we thank you all for being here.
Hey, Faye, this is Tommy.
Oh, Tommy, I'm sorry, I don't see you on my screen.
That's okay. Tommy East, representing the nursing home industry.
Thank you so much. Good morning. Did I miss anyone else?
Good morning. This is also Parham Jabari, Chief Deputy Commissioner for PDH on the call.
Thank you. I'm only seeing part of the pictures at a time, so if I miss you, please step in. All right.
Deputy Commissioner for Community Health Services.
Thank you. All right.
This is Mike McMahon. I'm the Acting Deputy Commissioner for Administration for PDH.
Thank you. Who else?
And Jeff Stover, I'm the Executive Advisor to the Commissioner here at PDH.
Yeah, no excuse for that, Jeff. I knew you were here. Sorry about that.
That's all right. No problem.
All right.
Communications Director for BDH.
Okay. And is that it? Thanks, everybody. All right. So with that, Mr. Hilbert, could you review the agenda, please?
Yes, ma'am. Morning, Madam Chair, again, members of the board. The agenda for today's meeting is on the screen. First, we will have the approval of the minutes from the June 4th meeting. Next on the agenda is the Commissioner's report from Dr. Oliver. We will then have I will then provide the regulatory action update. And following a break, we'll have our public comment period. And as is the case, I'd like to review how the public comment period will work for today's meeting, and we'll review the procedures again before we start that item of the agenda. So when registering for this meeting, there was an opportunity to sign up to speak on any topic. The list of persons who signed up to speak was finalized at 7:30 this morning. Each person who signed up to speak will be called in order, along with the name of the next speaker who is on deck. And pursuant to the board's public participation policy, each speaker will have a maximum of 2 minutes in which to speak, and there'll be a countdown timer on the screen, and a bell will ring when the time has elapsed. If the bell rings while a person is still speaking, we'll allow that speaker to finish the sentence that they're on, and then the speaker will be muted, and the name of the next speaker will be called. And then following the public comment period, I will provide the legislative update for the special session that is currently underway. Stephanie Gilliam will provide a budget update. And then we also have on the agenda the recommendations issued by the board's public policy subcommittee that was formed after the June meeting. After that, we will propose the board meeting schedule for 2021. And then after any other business, we will adjourn. And Madam Speaker, we received a request from Ms. Whipple to have a special presentation from Polly Rabel from BHHA at this meeting, and I would suggest that in order to accommodate Polly's schedule, we amend today's agenda to have her presentation following approval of the minutes. And in addition, I would like to also suggest that the agenda item concerning the board's policy subcommittee recommendations, that be moved until after the budget update on the agenda.
All right, is there a motion to add those, to amend the agenda for those two items?
This is Linda Hines, so moved.
All right, and do we have a second?
Second. This is volunteer second.
All right, so we have a motion and a second. Is there any discussion about that? All those in favor signify by saying aye.
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 All those opposed? None, the motion carries. The agenda is amended. And Mr. Herbert, I will just add, under other business, today we're going to hear from Dr. Jang, and she's going to ask for the opportunity to get a presentation on our next board agenda. So I want to make sure I don't miss that at the end. Okay. So, are there any questions from Mr. Hilbert other than that about the review of the agenda? All right, then we will ask Holly Rabel to give her presentation. And thank you for being with us.
Madam Chair, I think you wanted to
Yes,
do
sir.
the minutes from the last meeting first.
Oh, I'm sorry. I had marked that going in before the minutes. So that being said, is there a motion to approve the Board of Health meeting minutes from June the 4th, 2020?
So moved. Patricia Kinzer, so moved.
All right. So, and Wendy, is that a second from you?
It is second, yes.
Okay. So we have a motion and a second. Is there any conversation or comment? Seeing none, all those in favor signify by saying aye.
Aye.
Aye. Aye.
All those opposed? The minutes are approved. Thank you very much. Now, Ms. Rabel, your turn.
Thank you so much, and I really appreciate you all giving me the time today. I wanted to update you really quickly on some awesome work that has been going on with EDH and the Virginia Hospital and Healthcare Association. I'm sorry.
Say we need louder.
Yeah. A little hard to hear you, Polly.
Okay, I'm sorry. Can you hear me now? Yep. So if you would go to the next slide for me, please, that would be great. If you all recall, about 2 years ago, Dr. Oliver and my boss, John Snotton, who at Virginia Hospital and Healthcare Association, created a partnership called Partnering for a Healthy Virginia. They invited 30 of their close friends to be on this collaborative with them, and these were leaders of state agencies, hospitals, health departments, healthcare funders from across the Commonwealth, and they all had a common aim of improving population health. They're really trying to figure out and understanding, which I appreciate from them both, that moving the needle on population health would not be successful if we did that in a vacuum, that we really needed to work together to move that needle. So they hired me about 2 years ago. I have been working really closely with them and Dr. Filano, and we took this group through what's called a collective impact process and developed some shared goals, vision, and a mission. The 3 strategic priorities that this group agreed on, I would love to update you on at another point in time, but I know that time is short. And so the one I really wanted to focus on today was the strategic priority around using engineering data to help clearly define root causes and the effects that they have on the people of the Commonwealth. So if you would go to the next slide, please. I think that everyone at this table knows and understands that 80% of a person's health happens outside of a doctor's office or a hospital. There are many social determinants of health that affect health outcomes, including transportation, education, food, employment, many things like that. So what we know is that when someone comes into a hospital or a healthcare facility, coordinating with community-based organizations and government entities is really the solution to improving health outcomes for our patients. We can't just look at what is physically wrong with them, but we have to look at the drivers of that illness. So the key in doing that is really ensuring that we have some kind of system that allows us to share information and integrate our work. So if you look at the next slide, Partnering for a Healthy Virginia, one of the ways that we define the problem, this is just putting that problem into a picture, is that you have a patient here on the left-hand side, and you have this patient's getting services from both the community, government organizations, and healthcare, but none of those systems are able to talk to each other and they're not able to share information. A lot of times that is done, phone calls and things of that nature. So that's the current problem that we have in the Commonwealth. You go to the next slide. What we decided to do as Partnering for Healthy Virginia is really survey the different groups that were working on social determinants of health and who was screening on social determinants of health and who was referring around those social needs. So we did that. We surveyed lots of different entities, and we knew that there were health providers out there that were screening and referring, but they were using different tools in different places in different ways. So at a health system, you may have an emergency department that was doing some screening, but that was it. Or you may have a health department that was doing some screening in one particular part of the health department, but not across the entire department. We also found that there were varying standards for evidence-based outcomes for those connections that they were trying to make. So what does a closed referral mean? What does a positive referral mean? How do we know that we're actually helping people improve their access to some of those social needs? In Virginia, the primary electronic health record is EPIC, and we knew that EPIC had a screening mechanism for social determinants of health built into it, and it could connect to a resource guide if a hospital had one, but those are really expensive to build, and they are very time intensive to maintain. As you know, working with community-based organizations, they have a lot of turnover, hospitals have turnover, health departments have turnover, their services change, so it's really hard to maintain those databases. We knew from talking to our federally qualified health systems that their electronic health record also had a built-in screening tool, but we also knew it wasn't being consistently used across all of those systems. We also knew that our managed care plans were doing some screening, especially for Medicaid, Medicare patients within 30 days of enrollment, but we're having some success, but it was a relatively new process for them. So all in all, what we found is that there were tons of systems being used across the Commonwealth. None were standardized, none were talking to each other. And so we weren't able to use that data in a meaningful way to really identify what the needs of the Commonwealth were and where we might need to better put resources. So on the next page, Partnering for Healthy Virginia created an E-Referral committee. And we have about 50 people on this committee that represent hospitals, health departments, community-based organizations, government organizations of all types. And we charged this group with really 3 outcomes. The first was, can we create a standardized screening tool for social determinants of health that could be adopted by the various entities sitting around the hospital, the table, sorry. Number 2, could we come up with a Commonwealth-wide e-referral platform that we could help connect patients to social needs? There are a couple of things that we were looking for in that platform. Number 1, we wanted to be able to track the gaps in services and determine how that relates to social determinants of health. We wanted it to be a multi-directional platform so that information could be shared back among the different partners that are working with a patient. And the third charge for that committee was to really look at our system of connectors in the Commonwealth. Connectors can be anything from community health workers, navigators. These are the folks that actually help people get from point A to point B. So you can have a really great system, but if you don't have a system of connectors that help people, the likelihood of them being connected successfully to social needs is pretty small. So we started working and looking at all these different systems that were being used across the Commonwealth, and we found that there was one system that was being used more than others, and that was a system called Unite Us. So we went to them and we partnered with them, and we created a proposal for getting Unite Us across the entire Commonwealth of Virginia, and we called that Unite Virginia. So we wanted government agencies, community-based organizations, health systems, connectors, all to have access to this system. And we took that proposal to PHB to get their buy-in. So when we did this, there was a network that was already using Unite Us in Southampton Roads. There was also one that was coming in Harrisonburg and Rockingham. The entire state of North Carolina uses Unite Us, and there was a new network being built with help from Kaiser Permanente in Maryland, DC, and Northern Virginia. So we were really kind of surrounded on all sides by Unite Us, and luckily it's also just a great product that really kind of met all the needs that we were looking for in an e-referral system. So we got the standardized tool created. That was being tested among end users. We got a proposal together to put Unite Virginia together, which is this e-referral system, and we had gotten the buy-in of Partnering for a Healthy Virginia. We're in the process of trying to find funding for this system. And then, if you go to the next slide, as everybody knows, COVID happened. And so people had to work and scramble. My biggest regret is that we weren't 6 months to a year further down the road with our Unite Virginia product, because I think this would have been, I don't think, it would have been a really incredible tool to use during COVID. But what we do know is that COVID is not over, and that the fallout from COVID will be felt for many months and years. And so the bridge between the social needs and healthcare is more important than it ever was. So what we quickly did is we rewrote our proposal to really fall in line to address the public health emergency that was currently happening in Virginia. And if you go to the next slide, there are basically, there are 3 phases, which I'll talk about in just a minute, but we built this plan to do a couple of things. Number one, we wanted to quickly get these networks up and running, particularly around specific needs that we were hearing about and finding, which was food, housing, transportation, medications, in a lot of instances. We wanted to develop a coordinated process to help people get to the emergency services that they needed because of COVID. And then we wanted to find out what were the outcomes of those referrals, so that we could figure out where the gaps in services were across the Commonwealth. And we wanted to do all this by building a system that would last, and building an important public health infrastructure that we needed longer term across the Commonwealth as well. So if you go to the next page, what we basically did was take our plan and reworked it so that it was in step with crisis response modes. In the response phase, what we wanted was for our contact tracers and our connectors and our community health workers and navigators across the Commonwealth, as they're coming in contact with people who need to isolate and quarantine, to be able to use the system to help them do that. As we move into the recovery phase, the economic implications of this particular outbreak will have really lasting effects, and trying to help connect people to education and jobs will be something that we will need to do as we move through the recovery cycle. Through mitigation and through all these phases, we want to try to, again, identify where our gaps in services are, and to help communities bounce back from this particular emergency. And lastly, we want to be prepared for the next emergency. We believe that this infrastructure will allow us to do that. Having this public health infrastructure in place would allow for that. So on the next slide, to be responsive to the current crisis, we created a 3-step approach to this work. And we put together a proposal with Dr. Oliver and Dr. Forlano that we submitted for CARES Act funding. That proposal looked at a 3-step approach. The first is to really build these networks in target regions where we found the most cases of COVID. And so that would be Southampton Roads, which already has a network, but we would build it out, Richmond and Northern Virginia. That network would focus primarily on critical needs, like food and housing, medications, mental health, social isolationism, those types of things. The second part of the process would be to build those networks in other places across the Commonwealth. and also continue to build the different domains of services that were added to the database. And the third phase was really about strengthening. How do you optimize that network to ensure that that it's solid and in place and is ready to use should we have another emergency. So on the next slide and the few slides that follow, there are more details about every step of this particular process that we've put together. But I also know that time is of the essence with this meeting, and we got a late start too. So I don't want to take up too much more time. I did put a couple of extra slides in there that you all could look at your leisure. But essentially, I want you to know that we have put together this plan. We have submitted that plan for funding. VDH has actually, and we're really proud of this work and proud of the fact that we might be able to take advantage of a crisis to build a public health infrastructure that will meet the needs of the Commonwealth for years to come. And so given that amount of time, I just wanted to ask, are there any questions, Dr. Furlano, Dr. Oliver, you guys might want to add to what I've said?
Any questions for Ms. Revo? This is really wonderful.
Yeah, I'm sorry, Faye. I just wanted to, this is Dr. Puris. Can you hear me?
Yep.
I'm chair for Sequin, which is the Centera Quality Care Network, which is looking at obviously population health as well. And I just can't thank you enough for this work. So much of medical care is basically trying to close the barn door after the horse is already out. And to be able to understand all of the things that go into patients' often inability to follow through on physicians' best laid plans, really that infrastructure is critical for us keeping people healthier. And I just wanted to compliment you. This is very difficult work and very detail oriented, but just very exciting, and I think will have so much positive effects in the future that I'm really excited to hear about it. So thank you very much.
Thank you, and thank you, Sarah, for being the leader in this work.
Absolutely, and this is Linda. Again, I agree, such great work, such needed work. I would also, I wasn't sure I saw it on the E-Referral and the connectors, but I would also like if this could connect to some of the managed care companies, as they have resources as well to help to fill those gaps and to fill the need that people may have in the community. But excellent work. We really need this because, as we know, if people don't have housing or food, they're not going to seek health care. So this is excellent.
Yeah, and we are absolutely, it is in the plan to have managed care at the table as well. And so Optima, again, with Centera and Optima, they've been kind of starting this work and leading this work on both sides of that. But our plan is to bring everybody into the fold. That's what our hope is.
Question, this is Wendy Klein. Again, I applaud you. It's nebulous a little bit to me how this will be operationalized in the future. Can you just give us a little bit of vision for next steps?
Yes, ma'am. Yes, ma'am. So what we're doing now is looking for the funding to build the network. And once we have the funding to build the network, we will start building that network in 3 places. If you could turn to the next slide really quickly, I think this might help to answer your question, Ms. Klein. Unite Us has done this across several states, and they have a really solid process for getting it done. I will tell you, it's one of the reasons that I was sold on this company as opposed to some of the other e-referral companies out there. They have a really solid process for going into communities, bringing everybody to the table, socializing them about the system, onboarding them to the system, and continuing training. They also help make sure that the system stays up to date, that it is that those resources are constantly checked, and that there are rules and regulations about how you respond to the information within the system. It is HIPAA approved, FERPA approved. It's everything approved. Does that help at all? Does that answer your question?
Dr. Klein?
Yes, it does. And it includes the safety net?
Yes, ma'am.
Okay.
Yes, ma'am. All the FQHCs, all the free clinics, they've all been a part of this process with us.
Thank you.
Yes, ma'am. I don't think this will work very well if everybody's not in it. So we really tried to cast as broad a net as we could.
All right, are there any other questions?
I just like to, this is Benita Miller, just say this is awesome work, and it could be a template, nationally for other states, but this is amazing what you've done, because I know people have worked for years to try to coordinate something like this, so that's awesome. And I would hope that you will keep oral health care in mind as well.
Yes, ma'am.
And maybe consider partnering with Virginia Dental Association or Health Catalyst, which used to be the Oral Health Care Coalition, because I think we can also help provide resources and be of help in that networking.
Yes, ma'am. Health Catalyst is part of Partnering for a Healthy Virginia, and they sit on our E-Referral committee.
Okay, great.
Yes, ma'am.
Great.
And I will say, like, we haven't done this yet, right? The hardest part is finding the money. And I would be remiss if I did not thank Dr. Oliver and Dr. Forlano. They have been nothing but 100% supportive of this process and have helped me tremendously in trying to get it up and running and put together. And so really, this is something they've been 100% supportive of and active in. So really, thank you, Dr. Oliver, and thank you, Dr. Forlano. I'm really grateful.
Great. All righty.
Babe, one more question?
Sure.
Hi, this is Jim. I'm glad they're building off of some existing systems. I'm concerned in particular about the Northern Virginia system, which is a part of a group that includes Maryland and DC. Is what you're doing separate from that fully, or will the Northern Virginia municipalities and providers have to connect in two different places?
No, ma'am. No, sir. I'm sorry. So the way that this will work is that, and this is kind of the beauty of it. So we do know that we have patients that move from DC to Northern Virginia to Southampton Roads to North Carolina, right? So they are different networks, but we've already spoken to Kaiser Permanente. They are very interested in being connected to our network, and that is not a difficult thing. You basically would send a note that said, hey, your patient has come here to Virginia. We would like permission to access their notes on care coordination. And they could get that pretty easily. Same with North Carolina. So we've spoken with both of the, and I sit on that, the board that Kaiser Permanente has put together to create their network. So we have worked and talked with people about being able to share information between networks. So and because we're all using the same system, that's a heck of a lot easier than if we were using different systems. So that's the plan as of now.
Okay, thank you.
Sure.
All right, anyone else? All right, thank you so much. This is a wonderful presentation, and we appreciate your taking the time to be here with us.
Appreciate your time. Y'all have a good day. Thanks very much.
So I just want to take a second. As I was making introductions this morning, I left out a couple of people. I left out Alex Jansen and My Lamb, and Alex keeps every train running on time, and we could not do this without her, and the support from Mai is incredible. So I don't want to let them sit in that Madison boardroom and not acknowledge how hard they work to keep us working. So it is time for the commissioner's report, and Dr. Oliver, we are always happy to hear from you, but right now seems like one of the most vital things we do is to talk to you. So the floor is all yours.
Thank you, Madam Chair. Can you hear me?
We can.
Excellent. Well, thank you, Madam Chair and members of the board. I'm glad to be here this morning and I'll be able to present to you. Next slide, please. I'll be covering a number of very different points here. that you can follow along on with your board packet. The first one that I'll be dealing with, next slide please, is the current status of COVID-19. And if you can go to the next slide. Here is a graph that depicts the number of cases by date of symptom onset, the epi curve for the disease. You'll see that we've had two peaks of COVID-19 in Virginia. The first one, of course, being earlier this year with the rise of cases from March and peaking in May, where we had at our highest point a 7-day moving average of about 1,036 cases. In early May, that began to slow down. Incidents, as you can see there, sharply dropped until the end of the month. We be opening in mid-May and went into phase 2 of phase 1 rather, and then later on, and at the beginning of June into phase 2, and then phase 3 reopening in July. Nova was had our greatest number of cases in the state in that first peak. Because of that high number of cases there, they were delayed a little bit on the reopening process. After the reopening, a few weeks later, we saw another spike in cases as it happened in a number of states around the country, and that second spike peaked again at around 1,000, more over 1,000, about 1,013. Next slide, please. Unlike the first peak, which was driven largely by cases in Northern Virginia, we can go to the next slide.
I think you wanted the one before this.
Alex or Mylan, whoever is driving the slides, I need to go to the next one.
I think he wants to talk about the one about Eastern.
So go back.
Go back to the one, 2 before this, that one. I think that's where he wants
Thank
to be.
you. Unlike with the first spike, this, which was driven primarily by cases in Northern Virginia, the second spike was driven by cases in the Eastern region, where you see here where that spike occurred over those dates in just over this past month or so. It was also in part driven by the rise of cases in Southwest Virginia. As you know, the governor enacted an order on with regard to the Eastern region to restrict bars and restaurants and gatherings there, as well as social gatherings. The Southwest region's surge had a different sort of character than other regions, or even the Eastern region. What we saw in the Southwest was essentially that it was just a lag, right? While the rest of us had our cases rise over April and May, cases were relatively low in the Southwest, and they started to rise gradually. So it wasn't a resurgence, but just the gradual growth of the cases there in the Southwest that led to it being one of the causes of the second spike. Next slide, please. Most of our cases have occurred among people who are less than 70 years of age, 91% to be precise, but 74% of the deaths are in people 70 years old or older. And hospitalizations have been primarily in people 50 years or older, about 72%. As many of you know, communities of color have been disproportionately affected by COVID-19. 34% of the cases have been among Latinx populations, whereas they only make up about a little bit less than 10% of the population. 26% of the cases are among African Americans, who are about 28% of the population. That's also been reflected in the hospitalizations, where 31% of the hospitalizations have been among Latinx communities, 29% from African American communities. The deaths have also been disproportionate, with 11% among Latinx, 26% among African Americans. Next slide, please. This slide depicts our testing. We've looked at our percent positivity rate, which is the proportion of positive tests out of the total number of tests that given. At one point, we were over 20% in our positivity rate, and that has dropped down. We're now currently around a little over 6% across the Commonwealth. This is a measure really not of prevalence, but of how well we're and how broadly we're testing. This is, we shot for being below 10%, which we've done for a couple of months now, although we would like to get even lower than that. A big challenge in doing appropriate number of testing or more testing has been the ability of labs to access reagents and other supplies for testing, and that continues to be a challenge. Next slide. And next one after that. Thank you. So we have attempted to find other ways of let me have the next slide, Jesse. So this shows, again, that's another picture of how well we've been doing on the testing. This graph here, you can see that we've exceeded our goals. That dotted line across the graph there shows you where our target was, and we exceeded that in both July and in August, hitting going over the mark. And we continue to try to do our best at trying to get out to as many communities as possible, covering outbreaks, going to congregate care sites and other places to test people for COVID-19. Next slide. We've had, from a public health point of view, really focused a lot on vulnerable populations in our community testing. As I said, the congregate settings are important ones for us to cover with point prevalence surveys. And of course, being able to respond to any outbreaks remains a important priority for the health department. We're trying to increase our capacity for testing, as is noted here. In particular, the one lab model is a very important initiative. The state lab, DCLS, is developing contracts with academic centers across the Commonwealth, and that way will greatly increase our ability to do public health testing for COVID-19. In addition, the DCLS itself is increasing its own capacity. Just a week or so ago, got a couple new high throughput machines, and is looking at other ways of really increasing its capacity. Next slide, please. The community testing, as I said, has really been focused on vulnerable populations, our 35 health districts, so take lead and working with community partners such as the Community Health Center, those street clinics and others in really focusing in on those communities which are particularly hard hit by disease and that they get adequate tests. Next slide. I mentioned that we've been doing point prevalence surveys. These are testing events in which we test all individuals in a particular site at one particular point in time. We have covered all the skilled nursing facilities that wanted to have such surveys done. We've started to do the same in assisted living facilities. We had a lot of help from the Virginia National Guard in carrying out these PPSs. As you can see here, they completed 376 missions and helped us cover 223 nursing facilities and 65 assisted living facilities. The extension of support from the federal government allows the Guard to be redeployed. We this week are working and training 4 teams of the National Guard who will be beginning next week and helping us continue this work. Next slide. This graph shows the changes in test turnaround time. You all are quite aware of the fact that earlier on in July we were having really long turnaround times for testing. That has improved a great deal most recently, and we're down now to testing being able to occur in anywhere from less than 24, around 2.5 days. Even at the commercial lab. So that's been a big step forward. And we, however, still continue to look for alternative strategies to increase testing capacity. Next slide. One of those alternative strategies is a multi-state compact agreement. Governor Northam entered into a multi-state compact with 9 other states. This was being led by Governor Hogan in Maryland. The idea behind this compact, of course, is to look at putting together some bargaining power to obtain antigen testing machines from 2 of the leading manufacturers of that technology, and be able to use that for in the early days of disease, if there's a way to detect symptomatic patients. And also we've been looking at it for rapid screening of asymptomatic and pre-symptomatic individuals. Next slide. As I mentioned, the idea behind the compact is, of course, to with having 10 states working together on this, gives a real incentive to manufacturers to increase test production. Each of the states is looking at trying to obtain 500 tests for each state, and this we hope will encourage this production. We're working through issues like how they do the procurement for the participating states, and looking at the various policy issues that come up with respect to how would we use these 500,000 tests should we be able to obtain. Next slide. A big help in trying to figure that out, this question of where we would use such testing is our Testing Advisory Council, which has been discussing ways in which antigen testing can be helpful. I already mentioned the one lab model. We're seeking more funding of CARES Act dollars to ensure that that is fully implemented, and putting together regional strike teams so that we can supplement the work that the National Guard teams will be doing and conducting testing around the state. Testing, as you know, is not an end in itself. It's part of a containment strategy to box in the virus by identifying cases as quickly as we possibly can, putting those cases into isolation, finding any contacts of those cases, quarantining them, and in that way prevent the spread of the virus and box it in. So the next aspect of what we want to do, in addition to the testing, is the following up with the case investigation and contact tracing. If we go to the next slide. And thank you. So contact tracing, again, is really key to this strategy of boxing in the virus. We've made a lot of progress on our contact tracing. It was a huge lift for the health department, and some outstanding work was done to achieve this. We increased our workforce by more than 33% in just a couple of months, trained all these new employees, developed metrics to measure how we were doing on our case investigation and contact tracing, and now are in the process of developing regional surge teams who can back up local areas when they have a surge and need extra help in the contact tracing and case investigation and so on. Another part of our very important part of boxing things and augmentation of our contact tracing is our new exposure notification app, which is called COVID-Wise. Next slide, please. This slide was prepared last week. So the data is a little bit old. We launched the COVID-Wise on August 5th, so today is 4 weeks out from the launch. We currently have 479,123 downloads of the app. About 2/3 of smartphone users own Apple iPhones, and 1/3 own Google or Android smartphones. And so that's the breakdown in that 480,000 or so. This number represents about a little bit north of 11% of adults 18 to 65 who own smartphones, which is a very good achievement. In comparison to countries, it's been mostly countries that have adopted this exposure notification apps based on the Google Apple exposure notification system. Google and Apple will say that less than 10% is minimal uptake, and over 10% they consider moderate uptake. So we've hit a moderate level in 4 weeks of work, so that's been quite good. The line graph there gives you an idea that we've had a real steady growth day to day, getting about, about 15,000 or so downloads every day. Next slide. We have gotten a lot of coverage on this new application. We've more than 5,000 stories at this point in local press and media, bunch of broadcast stories, news stories, a lot of social media coverage as well, including, and again, of course, our biggest one so far has been the CNN spot that we got about a week ago. Next slide. This is our landing page, covidwise.org, where folks can download the application, get information on it. There's a FAQ, lots of other information they can obtain there. Of course, they don't need to go to that page. They can go directly to the App Store, to Google Play, in order to get that application. As of a couple weeks ago, we had about 256,000 unique visitors to the page, over 500,000 page views, lots of people returning to look at that page. Next slide, please. Advertising for the this is being done by Madison, Maine. They I don't know what you call it. The tagline or whatever they were using is, add your phone to the fight against COVID. And we've provided all sorts of materials for people who want to use these graphics to help publicize this, and we're doing it in both English and Spanish. Next slide. For all kinds of reasons to use it. It's free, it's voluntary, it's anonymous, it's easy to use, and hopefully we will get many more to download this app and to use it. Next slide. I want to shift gears and talk about long-term care facilities and some other settings. We'll go to the next slide. These data here are data that you can get at our website, our daily dashboard, which is on the VDH website. The key takeaway here is something that I think you all are quite aware of, which is that while that the number of cases in long-term care facilities, so this is skilled nursing facilities and assisted living facilities, has accounted for 55% of our total cases, but the deaths in our long-term care facilities have accounted for about 95% of the total deaths. This is a population that's particularly vulnerable to COVID-19, and that's been indicated by that very high number of mortalities there.
Dr. Oliver,
yes.
I'm sorry to interrupt. I just wanted to clarify that the figures that Dr. Oliver just stated are specific to cases associated with outbreaks. So that's a much different figure than our total cases. Long-term care facilities residents of long-term care facilities account for approximately 6% of all cases. But if you narrow that down to outbreak cases, then it's the 55%. So I just wanted to make sure that was clear. Thanks.
Thank you, Dr. Folano, for that clarification. Can we go to the next slide, please? So taking off on that point, this shows the outbreaks in long-term care facilities that have occurred over time. So we had a big peak in those outbreaks in April, and another peak in July when we moved into phase 3, and that was around the time when we were seeing the increased community transmission in that second spike. One of the things that is really clear about outbreaks in the long-term care facilities is that they are associated with widespread community transmission of the virus. So in that first peak that we looked at earlier, where the widespread community transmission was really particularly the case in Northern Virginia, the outbreaks in the long-term care facilities were also concentrated in Northern Virginia. In the second peak, when we had the eastern region and southwest regions being the places that had the widespread community transmission, the outbreaks in the long-term care facilities were occurring primarily in those regions. So those two things are tied together, and it's something that we have to keep in mind as we move into the fall with schools opening and a possible, we've seen some spikes in number of cases associated with those openings, and we have to be really vigilant and try to mitigate against that so we don't get some community spread that then can blow over into the long-term care facilities once again. Next slide. So there is some updated nursing home recommendations. You may have heard about this coming out of CMS. When you look at the slide deck on your computer, those hyperlinks will take you to the newly released guidance from the CDC, as well as the new CMS requirements. And I think on that bottom bullet, the VDH nursing home reopening guidance is something that you all should take a look at as well. Next slide. In these guidelines, what is projected is that staff and residents of nursing homes should get tested if they have any signs or symptoms of illness concerning for COVID-19. In addition, testing should be done in response to any outbreaks. An outbreak is defined in these guidelines as any healthcare personnel or any nursing home onset of COVID-19 infection in a resident of a nursing home. And upon identification of even a single case of COVID-19 infection in any staff or residents, then all staff and residents should be tested. So a point prevalence survey would be conducted, and all staff and residents that tested negative would be retested every 3 to 7 days until testing identifies no new cases of COVID-19 for a period of at least 15 days since the most recent positive test. This is going to place a lot of new demands on skilled nursing facilities, and it's something that our long-term care task force is grappling with now and trying to provide guidance for how this can be carried out. Next slide. This routine testing of staff is another requirement coming from CMS. Facilities are being instructed to monitor the test positivity rate in the county every other week and adjust the frequency of testing based on that. As you can see from this table, The requirement is that if test positivity is less than 5% in your county, that you can, you're then allowed to test your staff once a month. And then if the test positivity is between 5 and 10%, then it's once a week. And if it's greater than 10%, it's twice a week. Next slide. This table, you can get details on this as noted there by looking at the reopening guidance document that we have the hyperlink for in your deck. It just shows some ways in which mitigation in the nursing homes is modulated based on the phase in which we're in. As you see, when an area is in phase 3, there's visitation, social group activities, and so on. There's fewer restrictions on that. Can I see the next slide? Before I go into the schools, I do want to just mention that in addition to these new regulations and coming out of CMS and the guidance from CDC, there has been from HHS indication that they're going to be sending antigen testing to skilled nursing facilities, and this would allow for hopefully being able to carry out this increased amount of surveillance that's being required in nursing homes. The last time that I looked of the 280 plus nursing homes that we have, only 23 had received these antigen machines, and we don't know how soon all the others will receive the machines. As with other testing situations, reagents and other testing supplies are still challenged in many cases, as well as the training of staff to put themselves in this situation of being a testing a lab as well as a long-term care facility. These are all challenges that we are working with our partners in long-term care to try to overcome. Shifting gears, talking about mitigation measures in K through 12 education. We've worked very closely with the Department of Education in mapping out guidelines and guidance for all phases of for Virginia, and plan for reopening Virginia. The focus for the recommendations that we've made for reducing COVID-19 in school environments has been around these bolded items here on this slide: increasing physical distance within the schools, ensuring that staff, students are wearing cloth, face coverings, and we've recommended that for all students and staff as developmentally appropriate. Health screening has been another guidance that we've made. Increased hygiene within the schools, as well as thinking through how to do cohorting in the schools to limit the number of people gathering in any one place at one time. Next slide. The guidance was geared toward the different phases of the reopening. In most areas now we're in phase 3, in which it is possible to have in-person instruction, although again, we've worked with local school boards to look at the conditions in their local area as far as how much community transmission there is there, and modifying guidance based on that information. Next slide, please. In working with the local school districts, our health districts have utilized our pandemic metrics dashboard, which looks at a number of factors that are indication of disease in that locality, so that we can then be able to advise the local school boards regarding whether or not there is low, moderate, or substantial community transmission of the virus causing COVID-19, and then based on that, be able to provide recommendations, guidelines, and guidance regarding the level of mitigation that would, or measures of mitigation that would be appropriate for that type of transmission. Next slide. We've done quite a bit to help get this guidance out to the superintendents in the local areas. We've had weekly meetings on the Zoom call with DOE and the superintendents to discuss these guidelines. The EDH has also organized regional webinars to discuss school guidance and recommendations from DOE and DDH. As I said, our local health departments, school nurses, local pediatricians, the superintendents have all been involved in these conversations. We've had specialized webinars for just the school nurses and other staff to provide information from our subject matter experts to discuss things like contact tracing and other ways in which we might be able to help the school in mitigation of COVID-19. And of course, our website has a ton of information that's available to educators, other staff, students, parents, and clinicians. Next slide. Keep going. So, on enforcement, a number of the executive orders that have been promulgated over the last, over the course of this pandemic have charged VH with enforcing various aspects of the guidelines related to the different phases of Forward Virginia, and this just goes through those in a little bit of detail that you can all read on your own. You can go to the next slide. A large part of what we've been trying to do is to educate. VDH is not a policing organization, and we've been really focused on working with restaurant owners, others who are impacted by these guidelines to try to get them to understand clearly what the guidelines and regulations are. And we've used social media and other media to try to reach out to the businesses to educate them. These visualizations here, for example, are depictions of material developed by our Office of Environmental Health Services for restaurants and other businesses to help them get compliance from their clientele to wear masks and maintain social distance within their facilities. And for each phase of the reopening, the Office of Environmental Health Services has really not only worked on this sort of marketing and communication campaign, but they developed trainings aimed at restaurant owners, for example, so that they could better understand the requirements and expectations of them for each phase of the reopening. Next slide. So you can take a gander at this slide and see all the various ways in which we've been charged with enforcement. I will highlight one particular issue that's come up. As you know, there's, some of you may know, in Hanover there's been a real challenge with one restaurant, in particular Calabash Seafood, which was openly defiant of the guidelines. We did the education that we talked to them, weren't really getting much help from them at all. We wound up actually having to suspend their restaurant permit, which we did at the end of July 27th. The owner, however, continued to operate without the VDH permit. There's a fair amount of media attention on this. One of the state senators actually went and visited the restaurant in support of the owner's refusal to comply with the orders. And on August 17th, the Office of the Attorney General actually filed a complaint and moved for a court injunction against the restaurant. I'm happy to announce that just a couple of days ago, Hanover County Circuit Court granted this temporary injunction, and Calabash is prohibited by the court from operating while its license is suspended. We're working with ABC as well on this and other enforcement activities, ABC is going to suspend their liquor license, and DOE is looking at ways of looking at how the emergency temporary standards are being implemented at Calabash. Throughout this entire process, next slide, VDH has worked very closely with the alcohol and beverage control, as well as with DDAC, the Department of Agriculture and Consumer Services. There are a number of facilities where we have been asked to enforce the guidelines of the various phases. Some of these facilities are actually regulated by VDAC, and in bars and restaurants, obviously the liquor license is issued by ABC. So working with these other state agencies has been really important in enforcing the guidelines. I'll also say that it's been clear that the majority of businesses have actually been very compliant, and even ones that have had some problems with maintaining adherence to the guidelines, going in and talking to them, educating them around those guidelines, and answering questions and that sort of thing. In the majority of those cases, we find that people are responsive and want to help and change their behavior. And it's relatively few that are really, really problematic. Next slide. A lot of people have been active in trying to help us in this enforcement effort, reporting people who have, in their opinion, have been violating the guidelines. We established an online complaint portal, and it was very active. Between June 14th and August 21st, we got 30,000 complaints. Our call center staff and local health districts have been fielding many phone calls around these issues, and to the extent that we can, we have been pretty good about following up on those complaints. Next slide. This is just showing again, the complaints went up as we opened up more, and with people thinking that phase 3 meant that we were completely back to normal, and we have to do a little bit of educating to bring that down, and it has come down. So that's a sign, I think, as I was saying, that most people actually really do want to adhere to the guidelines and protect themselves or loved ones in the community from COVID-19. Next slide. So we all hope we get a vaccine as soon as possible, or a treatment, or both, for COVID-19. COVID-19, if we and when we get the vaccine, we are going to be in an unprecedented effort to vaccinate millions of people in the Commonwealth of Virginia to protect the population from this disease. It will be a huge number of people that we will be attempting to vaccinate in a very, very short period of time. And it will require, as a result, a very robust partnership between public health and private providers, community-based organizations, free clinics, community health centers. All sorts of people will have to be involved in order to be able to carry this out. VDH has established a incident command structure back in June to begin work on these goals that we've identified and listed here in this slide. We have to develop a plan for statewide distribution and dispensing of the vaccines. You know, you read the news, there's what, $10 billion of federal money has been invested in the development of the vaccines so far, but nothing that I'm aware of has been invested yet in distribution plans for this. So we're planning as best as we can in that regard. We have to ensure that the immunization operations are really focused on the most vulnerable populations. We have to identify financial resources to help us carry all of this out. We have to maintain and adapt strategies to ensure that we have an adequate supply chain for this immunization campaign. There's a number of technology-based solutions that we have to institute to ensure efficiency and effectiveness of this response, as well as developing a really massive communication campaign to let people know about the vaccine and get them to get it. Next slide. There's a lot we do not know about the vaccine. We don't know what type of vaccine we're going to get, how many doses they'll need. There's all kinds of questions about storage and handling. I mean, you can read the list here. And what we do know about it varies and evolves from day to day. And as a result, organizing ourselves for this response is a very complex problem. For example, we know that one vaccine will require only one dose, but there's others that require 2 doses. And among the ones that require 2 doses, one requires 2 doses within 21 days, another one requires the second dose within 28 days. That's an extremely fast turnaround for giving someone 2 doses of a vaccine. It's complicated by the fact that the vaccines are interchangeable, so it's not like you can switch up between, we don't know about the varying presentations of side effects between the various vaccines. And there will undoubtedly be differences in how different populations will respond to the vaccine. And speaking of populations, we won't know a lot about how the vaccine impacts children and pregnant women. While they will attempt to do some testing of this in the phase 3 trials, we'll have very limited data. And as I mentioned earlier, communication and education around this will be a challenge. I read in, I forget where, Axios, I think, recently, that about 30%, they did a poll and found that only about 30% of African Americans currently say they would take a COVID-19 vaccine if it was presented to them right now. There's huge distrust around this issue because of the politicization, I believe, of the manufacturing of the vaccine, and that's going to present a challenge for us as we begin to launch a vaccination campaign. Next slide. So our incident command structure set up for this, our vaccination branch, has sort of organized our planning around the vaccination campaign in 3 buckets. One is the communications bucket, supply systems and data bucket, and the policy bucket. In terms of communication, we are developing talking points, frequently asked questions, documents, looking at how we're going to launch this massive immunization communication campaign. Hopefully we will get a vaccine that has gone through phase 3 trials. It's shown to be safe and effective, and will give us a means to really go out there and convince folks that they need to do this. In addition to the COVID-19 vaccine, of course, we're coming up on flu season, and we have our flu vaccination campaign to carry out as well. And the communities that are the most vulnerable to COVID-19 are the communities that we will want to really focus on with our outreach and communication. The supply systems and data, of course, we have to continue our work on looking at supplies that we have for carrying out the vaccination plan, doing things to ensure the supply chain during the H1N1 pandemic in the vaccination campaign that we carried out. One of the challenges we had was that at one point we had needles that were way too big for use in general population, and we're hedging our bets on that by now getting needles that are appropriately sized and stockpiling those even before we get the vaccines. I mentioned that we have to get some technology in place to ensure effective, efficient distribution and dispensing of the COVID-19 vaccine. So we're upgrading our immunization information system so they can handle much bigger amount of data. We have to ensure that we are able to utilize the system that VDH has developed for tracking the immunization, the VAMS system, and the gateway for connecting that is the IZ gateway connection. So we have to make sure that our immunization system can communicate well with that. We have to establish pharmacy agreements with the various pharmacy chains throughout the state, as well as provide information for community-based providers and the attestation for the CDs they need in order to be able to dispense the vaccine. The efforts that are being mounted to prepare for this vaccination campaign will be aided by the establishment of a vaccine advisory work group, which we've already begun to put together. We want to have a broad representation on this work group so that they can give us perspectives from varying points of view on the actions and policies developed by VDH as it relates to the COVID-19 vaccine and related vaccine preventable diseases. We'll have representations from both clinical and non-clinical organizations, subject matter experts, liaisons from various stakeholding groups. And we want this to be a sounding board also for the various communities that we hope to target in particular for vaccination. And we want to get some ethics input on this advisory work group, as well as ensuring that there's a health equity perspective there. All of this to really make sure that we do the best job we can in vaccinating the population against the virus that causes COVID-19. This campaign is going to cost a lot of money, and we have initiated a request to draw down dollars from the CARES Act to purchase supplies, equipment, to launch this communication campaign in the public. And we are putting together the final touches on our overall plan for the vaccination campaign, and we'll be submitting that to our federal partners on October 1st for their feedback. And I believe that is the end of my presentation, Madam Chair, and I am happy to take questions or comments from members of the board.
This is Jim Schuler.
Hang on just a second, Jim. Norm, I know we're going to have a ton of questions, and they may last as long as your remarks. And Jim Schuler will go first because he's had a couple things holding for a while. But I'm going to suggest we take a very brief, just 5-minute break here for those who need a break, because we've been in front of the computer for 2 hours. And then just as soon as we finish with questions for Dr. Oliver, we'll take a reasonable 30-minute lunch break. But I'm going to say, Jim Schuler, is that okay with you if we take just a very, very short break and then you go first?
That's fine. 5 minutes.
5 minutes, I promise. 11:05. We'll be right back. All right.
Just highlight yesterday, they changed the October 1st date to 30 days post.
Doctor, let me express my appreciation. I'm sure I speak for all members of the board on all the hard work that you, your staff, and all the health departments in the state of Virginia have been going through. I know it's been stressful, it's been changing every day. We're also stressed here in the New River Valley. We, not unlike other regions of the state that have major universities, are seeing a tremendous amount of influx of students coming back to Radford and to Virginia Tech. I know the university has been working hard to try to identify and prevent the expansion of COVID. But we are very much concerned with this great influx of students from many parts of the state and country that we're at the precipice of a future outbreak here in the New River Valley. I understand that Virginia Tech is testing all on-campus students, but they do not, unless I'm mistaken, testing any off-campus students, which is really 60% of the population of the university. Students live off campus. So it's a real concern amongst a lot of us here in the New River Valley. Are we at the early stage of something that's going to dramatically happen to us over the next 2 to 3 weeks? I know this is a hard question for you to deal with, but you understand my concern, because what the universities decide to do or don't do effectively affects K through 12 education when they open the schools. And there's been variations in different models, from Roanoke to Blacksburg to Galax, you name it, on how best to reopen up. And we're not in all agreement on how to do this. But do you get the gist of what I'm leading up to? Is our
I can move it to the next slide. You want to do that?
Well, it's the next
We are
slide, and
back?
then we need to go immediately to another document.
Jim should
Okay. All right. So as we start to regroup, Joe, I'm going to ask you to begin the regulatory action update.
Yes, ma'am. Madam Chair and members of the board, we'll have put the regulatory action update memo up on the screen. There it is.
Joe, can you be just a tiny bit louder?
Yes, I will. Can you hear me now?
Yep.
Okay. So, as you can see on the screen, we have 27 pending regulatory actions under development. You can see there the bullets of what different stages they are in. If we go down to the little bit bottom of the slide there, going down please, there you go. Since the June 4th meeting, the Commissioner has approved 4 regulatory actions on the board's behalf pursuant to the Administrative Process Act, and they're summarized here. I'll briefly go over them. I'll point out that these are all non-COVID related, and we are making efforts as an agency to we need to be doing our other work. And what you'll see here, just these 4 examples are examples of other things that are continuing to move forward in the health department. The first is dealing with rainwater harvesting regulations. The Commissioner approved a NORA on behalf of the board, and these regulations were mandated by legislation passed by the 2018 session of the General Assembly. And these new regulations are to provide standards for the use of rainwater harvesting systems, including systems that collect rainwater for human consumption. And the regulations that were mandated by this legislation are intended to promote the use of rainwater as a means to reduce freshwater consumption, ease demands on public water treatment works and water supply systems, and also to promote conservation. So the NORA was approved on that, and that one is moving forward. And if I have any questions as I'm going along, please stop me and I will do my best to respond. So
Sure.
the commissioners also approved a NORA for regulations dealing with sexual assault survivor treatment and transfer. So House Bill 808 from this past 2020 session passed regulations and passed legislation that was focused on hospitals, clinics, and physicians' offices, requiring them to develop, pursuant to standards coming out of the board, for the review and approval of sexual assault survivor transfer plans, pediatric sexual assault survivor transfer plans, and sexual assault survivor treatment plans. This was one part of many bills that passed last session dealing with this general topic. So again, a NORA has been approved by the commissioner for the development of those regulations, and that will be coming to you at a future meeting. Go down one more, please. Another bill that passed this in 2020 was House Bill 687. And this was focused on the certification of doulas, who are, you may know, they're non-healthcare professionals who, typically women who are providing guidance and assistance to women during the pregnancy and childbirth process. So the legislation that passed requires the board to promulgate regulations to establish requirements for the use of the term certified doula, as well as training and education requirements. Similar to legislation that passed around community health workers, the same type of idea that the Board of Health would be the entity that would determine the regulations for who can use the term certified. So that NORA was approved by the commissioner as well. So again, those are three non-COVID related items that are moving forward. The commissioner also approved on the board's behalf emergency amendments to the regulations for disease control and reporting, and also at a corresponding NORA, and this is focused on COVID. So these amendments to the disease reporting regs add reporting requirements specifically for COVID-19. So we had identified through the pandemic that there were some gaps in the types of information that we were getting when we received the COVID-19 disease reports. And these emergency amendments are intended to fill that gap. And as you can see on the memo here, the new provisions require physicians and directors of medical care facilities, in addition to simply reporting the confirmed cases, to also, as part of that report, to report any hospitalizations or ICU admissions. These amendments also require the case report forms to be submitted to us electronically. We clarify that that laboratory directors include pharmacies that hold CLIA certificates of waiver. We also require laboratory directors to report negative test results to us in addition to the positives. We also require that ethnicity data be included on the report. And we also add coronavirus severe to the list of infectious diseases that have to be reported to persons practicing funeral services. So again, these are emergency amendments to the disease regs that were approved by the commissioner on the board's behalf. And when we submit when these emergency amendments are published, they will also be published in the form of a NORA to start the process for making these amendments a permanent part of the regulations once the emergency regs expire. Just go down a little bit, Marlene. In terms of periodic review, just remind the board that we are required to review every one of our regulations at least once every 4 years to determine if the regulation needs to be amended, or if it should be repealed, or if it just should be kept as is. We have 13 periodic reviews in progress, starting on the bottom of page 2 and going on to page 3. I won't read them in the interest of time, but you can see that that's what they are. And if you scroll down a little more, as we always do, we give you a summary of the executive branch review activity that has gone on since the last board meeting. And you can see here we have summarized the actions that have been taken by the Office of the Attorney General, the Department of Planning and Budget, the Secretary of Health and Human Resources, and the Governor's Office. Madam Chair, we also, as we always do, we also, in addition to this memo, you have a more detailed matrix behind the memo in the information that was provided. And I'd be happy to answer any questions.
All right, are there questions for Mr. Miller? All right. Thank you, Joe.
Oh, wait a second, Faye.
What?
I'm sorry, got one question for Joe. The last bullet of the list regarding periodic reviews is one that is particularly important in the COVID era, it looks to me like. Regulations for identification of medically underserved areas in Virginia I don't know whether you prioritize all of those 13 items in that list, Joe. Is that a real high priority item? It just seems it's so relevant right now.
Yes, Jim, you make a very, very good point. That needs to be prioritized, and we will ensure that it is prioritized. Thank you.
Okay.
All righty. Is that it for everybody? All right, I don't think we need a break since we just came back from lunch, so we will move on to public comment period. Joe, do we have anyone signed up?
No.
Madam Chair, we do have one person who was signed up, but they are not present in the meeting.
Okay. Then I will close public comment period.
Hey, this is Patricia. I had a question since we have one extra second. I just had a question for Joe about the Doulas certification.
Sure.
What's the time frame for having those regulations created? What's the process?
So at this point, with the NORA being approved, we are moving ahead with working on draft regulatory language with the stakeholders, and don't have a specific time frame, but I would expect that will be coming forward, if not at the December meeting, the first meeting in 2021.
Okay, thank you.
All righty. In that case, Joe, we're going to move ahead to the legislative update.
Yes, ma'am.
Does that work?
That's fine, Madam Chair and members of the board. We have the legislative update for the 2020 special session 1 up on front of you. There have been a lot of bills introduced for a special session, and I would say that almost all of the bills that have been introduced dealing with the Health and Human Resources Secretariat, almost all of them are focused on the health department, which is not really a surprise, I suppose, since the purpose of the special session was to focus on the pandemic, and of course VDH has been front and center in responding to the pandemic and dealing with all of the associated issues. So we've been very busy with this. Again, If you have any questions as I go along, please let me know. So what the screen in front of you just has an outline on the general categories of bills that have been introduced. So what you're going to hear from me is I'm providing you with a description of some bills that are seeking to restrict or limit the authority of the board or the commissioner during an emergency. Other bills that seek to increase and improve the amount and type of data that VDH shares with the public concerning communicable disease outbreaks. There's been other bills that have been introduced that seek to establish priority groups of essential workers within the code for receipt of communicable disease testing or COVID-19 testing. There have been several bills introduced dealing with immunization. Some of these bills have sought to restrict or limit the authority of the commissioner to require vaccination during an emergency. But other bills have been introduced that seek to promote planning concerning the availability and distribution of a COVID-19 vaccine. There have been other bills that have been introduced that seek to require various types of healthcare facilities to enact policies to facilitate greater amounts of patient visitation by family members and friends. And then there have been some other bills as well that I will mention to you. Next slide, please. So this slide summarizes for you bills that have been introduced that seek to limit or restrict the current authority of the board and the commissioner to enact emergency regulations or emergency orders. Senate Bill, these three bills up here, Senate Bill 5025, House Bill 5023, and House Bill 5075, are all similar in nature in that they basically say that any emergency order or regulation adopted by the board is time limited. Depending on the bill, might be 15 days, might be 30 days, might be 45 days. They all basically say that the board can periodically renew these orders every 30 days or so for up to 18 months, and after 18 months, in order for that regulation to remain effective, we would need to go through the full Administrative Process Act procedure. And the other thing that's significant about these bills is that they say that the commissioner can only act on behalf of the board once. So you know the commissioner has authority in the code right now to act on behalf of the board when the board's not in session. So these bills would restrict that. In terms of the status of this legislation, Senate Bill 5025 has been reported from the committee and is either on the floor right now or has passed the Senate. The other two bills, the House bills, were not reported out of the House committee. They were defeated in that committee. So Senate Bill 5025 is still alive, should be heading over to the House for consideration. Next slide, please. So two other bills that also have the intent of limiting or restricting the board and the commissioner's emergency authority are House Bill 5025 and Senate Bill 5028. 5025 was defeated in the House Health, Welfare, and Institutions Committee. Senate Bill 5028 is still pending in the Senate Education and Health Committee, and 5028 is a fairly short bill. It says that the board may not impose any emergency order or regulation affecting the operation of any public or private elementary or secondary school. In fact, that bill also has the same language for the governor's authority. And I should have mentioned, the prior bills about the board and the commissioner's authority also were written to also limit the authority of the governor to act in those regards. And you'll recall that the emergency orders that have been issued by the board have always been tied to an executive order issued by the governor. So all these bills are focused on not just the board's authority and the commissioners, but also the governor's authority. Next slide, please. Okay, so the next category of bills that I wanted to share with you was bills that are dealing with the amount and type of data that VDH makes available to the public in connection with communicable diseases. So these two bills, House Bill 5048 and Senate Bill 5081, are both focused on communicable diseases of public health threat. And that's a term that is defined in the Code of Virginia. And it basically means that it's an illness as determined by the commissioner caused by a specific or suspected infectious agent that may be reasonably expected or is known to be readily transmitted directly or indirectly from one individual to another and has been found to create a risk of death or significant injury or impairment. So, communicable disease of public health threat. So what this bill is saying that the health department shall make available information about outbreaks of these types of diseases at specific types of facilities or settings on our website. There is an important provision in these bills. We have to do this provided that we're still able to preserve the anonymity of patients. So that's written into these bills, and that's important. And the information that we need to make available on the website has to include the name of the place where the outbreak occurred, the number of confirmed cases in that outbreak, and the number of deaths associated with that outbreak. Both of these bills have passed their respective chambers unanimously. So I would point out on these bills, you may recall that the health department currently on our website, we make available this type of information for nursing homes and assisted living facilities. This bill would codify that requirement, codify that practice, but also extend it to some other types of settings. It would extend it to schools, it would extend it to summer camps, and also any other type of medical care facility beyond just nursing homes, and also to any residential or day program service or facility licensed or operated by any agency of the Commonwealth. Did you have a question, Faye?
Joe, can I stop you here? Yeah, I do. So early on, I think you and I had a conversation, maybe you and Norm and I had a conversation. Someone had requested this kind of information and we declined to give it because at that point the death rate was very low, and it would have been very easy for someone to have done a very small amount of investigative work and found out the name of the patient, and there would absolutely not have been any guarantee of anonymity. Would that, in this case, still be under our purview? Could we say there's only been one person who passed away due to this in a facility? If we make that information public, it would compromise people's privacy.
Yeah, it's a great question. There's always a balancing act here, and that's what makes this challenging. I will let the board know that the agency has developed a communicable disease surveillance data release policy. This policy was developed in response to issues just like the one that you just identified. We drafted this, I worked on this in conjunction with Dr. Peak and her staff in epidemiology. we've sent it out to the local health directors just a few days ago for their review and comment. We've given them until, I believe, September 11th to provide us with feedback. We're going to look at their feedback very carefully and make any additional changes that are warranted. But that policy will be used as one of our tools in implementing this legislation.
Okay. Thank you.
The next slide, please. Another bill that is still pending is Senate Bill 5090. This is not, this is focused on communicable diseases in general, and it's saying that upon declaration of a public health emergency related to a communicable disease, VDH shall make available a wide variety of information that's summarized here on the slide. The total confirmed cases among the general population, the total confirmed cases among persons living in, quote, confined spaces, and that's a defined term in the bill, and you can see how it's defined there on the slide: nursing homes, jails and prisons, and group homes. And we're also required to develop and report COVID-19 pandemic progress benchmarks, and you see some of the items there. So again, clear expectation from the legislature with these bills that VDH needs to provide more information to the public than the legislature feels has been the case to date. So this will be, assuming that these bills pass, we will have to develop an implementation plan as an agency to make sure that this happens as intended. Next slide, please. Okay. Testing, as you all know, has been a huge issue throughout the spring and summer, and so it's no surprise that we saw bills introduced focused on testing. And Senate Bill 5095 and House Bill 5105, these are focused on communicable disease of public health significance. So earlier I mentioned communicable disease threat. Diseases of public health threat is actually a subset of communicable diseases of public health significance. Communicable disease of public health significance is also defined in the Code of Virginia. It includes, but may not be limited to, infections caused by HIV, bloodborne pathogens, and the tuberculous bacillus. So it's a wide range of diseases, and what this bill is doing is saying that for any of these types of diseases, any available rapid diagnostic testing shall be readily available to all, quote, essential workers. And so these bills are creating in the statute a prioritization of essential workers for purposes of receiving any available rapid diagnostic testing for these diseases. The list of essential workers that's on this slide is actually not the complete list that's now in this legislation. Following introduction, the Senate bill was amended in committee, and I think again on the floor, to add additional categories that include firefighters, private providers licensed by the Department of Behavioral Health and Developmental Services. So those were two more groups. So a long list of groups that are determined to be essential providers in the code. So the Senate bill passed the Senate unanimously. The House bill was not reported out of committee. Next slide, please. One other testing bill. This bill is specific to the COVID-19 virus, and it's simply saying that the commissioner shall ensure that residents and employees of nursing homes receive first priority for any testing for COVID-19. And that's been reported from committee unanimously as well. Next slide, please. Okay, as I mentioned, several bills dealing with immunization. These first two bills, House Bill 5016 and House Bill 5070, would repeal the authority of the commissioner to require immediate immunization of individuals during an epidemic of any disease of public health importance for which a vaccine exists, if the individual objects to the immunization on religious grounds. So right now, Section 32.1-48 of the code gives the commissioner the power to require immediate immunization of all persons in case of an epidemic of any disease of public health importance for which a vaccine exists. There is a medical exemption to the current statute. There is not a religious exemption. These bills would have created a religious exemption to that section, but as I mentioned, those bills were defeated in the House HWI committee. Another bill was also defeated in the House HWI committee, House Bill 5082, and this, as you can see, says no vaccine shall be required if derived from human fetal tissue, if it modifies the RNA or DNA of the person to whom it's administered, or if the development of that vaccine did not include preclinical testing on lab animals prior to clinical testing on humans. So again, none of these three bills were reported out of the House Health Committee. Next slide, please. The other bill that was introduced dealing with immunization is House Bill 5122, and this requires VDH to convene a work group focused on the availability of a COVID-19 vaccine. As you heard Dr. Oliver describe in his report earlier, VDH is already in the process of convening this type of work group. So we're in good standing to implement this legislative requirement. Next slide, please. Okay, big issue during the pandemic as it pertains to healthcare facilities has been the ability or inability of friends and family members to visit their loved ones who are in these facilities. So that issue has been the subject of a number of bills introduced. House Bill 5041 and Senate Bill 5042 have both passed their respective chambers unanimously, and says that during a public health emergency related to COVID, it's going to require nursing homes and hospice programs and facilities to establish protocols to allow patient visits consistent with guidance that's come out from the CDC and CMS. And the protocol has to address a number of requirements that are specified in the legislation. House Bill 5121 is a similar bill. That's still pending in committee. Next slide, please. House Bill 5144, another similar bill, similar intent, still pending in committee. House Bill 5140 is similar, other than just to say that it's focused on individuals who have been diagnosed with a terminal illness and death is expected to be imminent. And so both of those bills on this slide are still pending in committee and have not yet been heard. Next slide, please. A few other miscellaneous bills that I wanted to bring to your attention. House Bill 5018 was focused on all of the complaints that have been reported to VDH concerning allegations that certain businesses, individuals have been violating provisions of executive orders that have been issued by the governor related to various types of social distancing or wearing of face coverings in particular. As you heard Dr. Oliver saying in his commissioner's report, we've established an online portal that makes it very easy and convenient for people to submit complaints to the health department. Individuals are allowed to file complaints anonymously if they wish. This bill would prohibit VDH from accepting anonymous complaints alleging any violation of executive orders. This bill was heard in the HWI committee but was not reported, was defeated. Another bill is House Bill 5095. And this would require VDH to work with the Department of Education and the Virginia chapter of the American Academy of Pediatrics to develop criteria that could be used to assess the long-term impact of distance learning during COVID-19 on students' health, mental health, social and emotional development, and academic achievement. So this bill is still pending in committee and has not yet been heard. One other bill, Senate Bill 5118. This would require utilities that are regulated by the SCC to develop an emergency debt repayment plan for their residential customers. We're following this bill with respect to drinking water and drinking water utilities. It also applies to electric and gas utilities as well. Only a relative handful of our regulated, of the waterworks that we regulate are also regulated by the SCC. But we are following that bill. Next slide, please. And this is the last slide of bills that I have, Madam Chair, members of the board, just to bring to your attention. House Joint Resolution 5002 would call on the General Assembly to encourage the availability of hydroxychloroquine, or HCQ, for the treatment of COVID-19. So this bill was referred to the Rules Committee in the House, and the Rules Committee took I would say, a fairly unusual action. Doesn't happen a lot, where they reported the bill to the full House, but without any recommendation. So this bill is still on the House floor, on the calendar. Don't believe it's actually been brought up for a vote yet in the House. Two House resolutions, House Resolution 570 and House Resolution 582, would recognize racism as a public health crisis in Virginia. These bills are similar, they're not identical. One of them, they both call on the health department. One of them specifically mentions our Office of Health Equity, the other does not. Both of those are still pending in committee and have not yet been heard. And then there are a number of bills that would provide different levels of civil immunity to either individuals or different types of healthcare facilities related to actions they took or did not take with respect to the transmission of COVID-19 or any alleged failure to provide adequate care as a result of COVID-19. So those bills have been reported from committee. So Madam Chair, as you can see, a lot of bills have been introduced focused on public health, focused on the health department during the special session. It's been a very busy time. You know, it's been weird for me working on all these bills in August. I'm used to doing General Assembly stuff when it's cold and dark out, not when it's warm and sunny. But that is the legislative update, and I'd be happy to try and respond to any questions or comments that you or the other board members might have.
Are there any questions? Benita, you're first.
Oh, that's a first. No, I'm just kidding. So Joe, you do a great job keeping up with all this and explaining it really well. And I do have a question about when you say healthcare workers, is the General Assembly including dental care workers in that? Because technically we are healthcare workers, but oftentimes we sort of get left as the stepchild or an afterthought. And I just want to make sure I'm not incorrectly assuming that healthcare workers includes dental care workers.
Dr. Miller, what bill are you referring to?
So there's the one bill about the immunity, liability immunity, and also the prioritizing of testing. And I would also assume that when something comes up in terms of prioritizing vaccines, that dental care workers would be included in healthcare workers, because we're as great a risk as those who are treating COVID patients,
Right.
especially because of the aerosol, that sort of thing.
Dr. Miller, if you don't mind, I'll respond back to you offline on that. I don't have the answer to your question on the tip of my tongue, but I can get it for you right after this meeting and send you a note.
That'd be great. Thank you so much.
You're welcome.
Other questions? Jim?
Thanks. I have two. First, Joe, is there a need for us to set up a procedure as a board for an emergency meeting to extend an order that the commissioner might be offering under the terms of some of these bills? Or are the bills so unlikely to pass that it's just not to be a concern?
Jim, I would never, I'm not going to speculate on what the General Assembly may or may not do with any of these bills. If they did pass, if Senate Bill 5025 did pass, then your question is a very valid question, and we would absolutely need to develop a plan for implementing it, which may include, yes, a special emergency meeting of the board in order to do just that, yes.
Okay, then it'll certainly keep until after the General Assembly has acted or not.
Right.
Second question, I find some of these bills pretty objectionable, but has the governor taken a position on any of the bills that would impede the authority of BDH or others to take action?
Jim, yes, the governor has taken a position. He is opposed to Senate Bill 5025 and 5028.
I would also note that there is absolutely nothing that would prevent board members from speaking to their respective legislators about their opinions about 5025 and 5028. Other questions?
Okay.
All right, I don't see anything else, Joe.
I do.
Wait, Wendy, sorry.
As Jim, yeah, there are, as Jim said, some of these just make my head spin. There has already been executive order that addresses clarification of certain immunity from liability. Was there a reason that there are additional now pieces of legislation being put forward?
Dr. Klein?
Some of these bills, I mean, the other one that I really find just stunning is HJ 5002 about hydroxychloroquine. So I had two questions about that. What is the difference between an HJ bill and an HB bill? And what is the status of that bill, which is a ridiculous, the overreach there speaks for itself. And the other question I had is, with all of these bills, the governor can still veto them if they are passed. Is that correct?
So, yes, any House bill or any Senate bill that passes and goes to the governor can veto if he sees the need, if he wants to. House resolutions and House joint resolutions, Senate joint resolutions, they do not go to the governor. They don't have the force of law. They're an act of assembly, but they don't amend the Code of Virginia. They have the force of law in the sense that it's part of the acts of assembly, but they don't go to the governor. They don't amend the Code of Virginia. In terms of the difference between a House joint resolution and a House resolution, I should know the answer to that, but it's escaping me for the moment. I would say that I'm not sure that there's a distinction, but I'm not sure that there's much of a difference, honestly. In either case, it's expressing a sense of the legislature on a particular matter, and would seek to encourage or request some action be taken, but it's not the same as amending the law and saying the health department, you have to do this or you're in violation of the law.
Okay, thank you.
Okay, anything else? Catherine? Catherine, did you have a question?
No.
Okay.
Wendy actually asked my questions.
Okay.
Sorry. I'm fine.
All right, great. Then I think we are done and ready to move on to the budget update.
Good afternoon, Madam Chairwoman and members of the board.
Hi, Stephanie.
Hi. So I don't usually present in the middle of a session, and it's a little weird in the special sessions where, unlike the regular session, we have kind of set calendar dates by which certain budgetary milestones will occur. So we don't really have that calendar to know when those things are going to happen. So I don't have a lot of definitive answers for you today, but I can tell you what I know so far. So the first thing I wanted to mention is that the governor did introduce a new budget at the beginning of the special session. Agencies weren't given the opportunity to request any budget amendments, so there aren't any DDH specific requests that we put in that I need to report the status on. Now, so the table you see, it's actually identical to the one I presented back in June, because there weren't any additional additions or subtractions to DDH's section of the budget. The one big difference that happened in his introduced budget is all of those items that I presented back in June that were on hold. You might remember I said that a lot. All of those have actually now been converted into permanent reductions in the new budget. Next slide, please. So I won't go over them exhaustively again because we went over these in June, but I do have a listing of all of them here, just so you can see each of them. Next slide. So last week, the House members published their member amendments. The Senate has still yet to publish any of their own. Normally, during a regular session, both the House and Senate do put them forward, but the Senate may or may not ever actually put forward member amendments during the special session. They could just choose to wait for a committee or then conference amendments, which usually happen after the committee amendments. Again, with no schedule for when they're set to occur, it's hard to know when exactly we'll have more information. But the important thing to remember with member amendments is that they're kind of the first step in the GA's process of affecting the budget. So any member can put in an amendment for anything that they want to. So that doesn't necessarily speak to how the larger body feels about a particular item. They just give you an idea of what a particular member is interested in. And again, there's no guarantee they are successful, because once you get into things like the committee or the conference amendments, that's sort of larger groups agreeing to a concept, where these, again, are just usually driven by one patron in particular. During the regular session, it's not uncommon for a lot of things to change between the member amendments and the committee amendments. So I will just kind of go over the amendments that are out there that will impact DDH, so you are aware of them. So the first one here is the language-only amendment. It directs us to report on actual deaths and not on extrapolated projection of deaths for COVID-19 or other infectious diseases. The next one here is another language-only amendment, and it would allow dentists to administer the flu vaccine.
The way it's presently written in the member amendment isn't actually usable. I know a change to the wording has been suggested that would correct our issues with it. The last one on this slide is another language-only amendment, and it would require medical facilities that BDH licenses to allow patients with disabilities to be accompanied by a support person, or if they're going to be inpatient for 24 hours or longer, to also have a designated person allowed to visit them. Next slide. So the next amendment here adds $5 million of general fund each year for community health centers. This is in that pass-through section of BDH's budget where it's money we would literally just pass on to the community health centers. And then the second one on this slide is actually it's restoring the funding from one of those items that we were given last session, but then got unallotted and now it's a permanent reduction. This restores the $750,000 in general fund each year for the Sexual and Domestic Violence Prevention Fund. So next slide. So this first one, and these are items that aren't specifically in BDH's section of the budget, but do affect BDH. So this first one would authorize $10 million from that CARES Act relief fund that the state has for VDH and VDEM for COVID-19 public information campaign. The second one is $500,000 for one-time grant program for education and outreach targeting the Latinx community. And then the last one here probably sounds similar because there was also House Bill 5082 that would have had the same effect essentially, where it prohibits using vaccines derived from fetal tissue or that modifies RNA or DNA of the person or with any animal testing involved. And again, so the same patron who put in the bill that had this exact same effect has also put in this member amendment. And the budget bill does actually supersede the Code of Virginia. So if the member amendment was successful, it would carry the same, if not more weight than legislation actually being passed. But as Joe mentioned, the actual bill that he put forward, the HB 5082, failed to report out of health, welfare, and institutions. So it's unlikely that this budget member amendment would be successful. But again, anybody can kind of put one in for whatever they want. So next slide. So these last three items, again, are kind of back of the book things that affect state workers. So the first one would authorize that same CARES Act relief funding to provide 2 weeks of paid quarantine leave for state employees. The next one is similarly using that CRF federal funding that the state has for up to 80 hours of paid sick leave for state employees. And the last one involves hazard pay for various positions. Most obviously, some of the nurses and doctors that BDH employ would fall under that category. And so those are all the member amendments that, again, are right now. And again, that's just the House side. The Senate doesn't have any. Again, they're just the member amendments. There have really only been 2 bills that have had a significant fiscal impact attached to them so far, and it was the 2 that Joe mentioned for the outbreak data reporting, the HB 5084 and SB 5081. They did both unanimously pass out of their chamber, but when they passed, neither of them had the fiscal impact published. So neither of them went to the respective money committees. So I'm not sure if that's going to have any kind of impact on their success, but they do have a potential fiscal impact. A lot of the other bills have either been no impact or they're indeterminate because there's just no way for us to specifically quantify what they're asking for us to do. But hopefully, if those 2 outbreak data reporting bills do pass, there is a committee or a conference amendment put forward that will, produce the funding that we need from that fiscal impact. And that's all I've got right now on the budget amendments. Does anyone have any questions? I've stunned you all into silence.
Yeah, I know. Anyways, thank you so much. I appreciate all your hard work on this. I keep hearing over and over, these are unprecedented times, but I guess that's really true. Okay, we good? Then our next order of business is to review our board meeting schedule for 2021 and to adopt. Joe, we got that up on the screen?
Madam Chair, we actually need to do the board's.
Oh, I'm sorry, I skipped the subcommittee. I did not mean to do that. I apologize. So our public health policy subcommittee worked very hard, especially the amazing work of Jim Edmondson and Patricia Kinzer. I'm so grateful for all the work that you two have done, especially in putting this together, and all the people who served on that subcommittee. This is a really engaged group. And so, Joe, can we review the recommendations and what happens next from that subcommittee?
Yes, Madam Chair. Marlon, can you put the PowerPoint up?
Oh.
Okay. So, Madam Chair, I just wanted to give the entire board an update on the work of the subcommittee that was created following the June 4th meeting. So just by way of brief background, following at the June 4th meeting, you'll recall we got the initial report from the Commissioner on the overview of the COVID-19 response. And that presentation from the Commissioner resulted in a great deal of discussion by the board members, you'll recall, during that meeting, and a sense that the board definitely saw a need for really more resources, honestly, devoted to the public health system. And the board wanted to be proactive in that regard, established a subcommittee to come up with some recommendations. The first subcommittee meeting was held on June 29th. In preparation for that meeting, Jim Edmondson and Dr. Kinzer had collaborated and put together some thoughts of their own, some recommendations of their own, and they were discussed at that meeting, along with a presentation from our Health Equity Working Group that's been established within the Unified Command, and we also had a presentation on the VDH Policy Analysis Research Plan, just as a way of getting some ideas out there and helping to prompt some discussion. There was, following that meeting, that we scheduled a second subcommittee meeting on the 17th of July. And in preparation for that meeting, we solicited some additional ideas and suggestions from subject matter experts within the agency on many of the topics that Jim and Dr. Kinzer had identified. And we spent that meeting having a good discussion of many, many different ideas. And coming out of that meeting was the finalization of some recommendations to send to the governor, and those were developed with input from VDH staff. Next slide, please. So you have in your board packet for today, we've sent everyone another copy of the letter that the board chair sent to Governor Northam on July 28th. And in that letter, the letter identified seven broad policy recommendations, and those recommendations were further operationalized into 17 more detailed recommendations that were contained in the matrix. Next slide, please. So this slide just identifies for you the 7 broad policy recommendations that were stated in the letter to the governor dated July 28th. And I'll just briefly mention them here. I'll paraphrase. Increase vaccination rates by strengthening the Commonwealth's infrastructure for immunization. Improve the Commonwealth's disease surveillance and investigation system. Provide state funding to support the VDH Office of Emergency Preparedness. Establish equity officer positions throughout our agency. appropriate funding for use in targeted communities that have been disproportionately affected due to structural and societal inequities, increase state support for the healthcare workforce, and finally, strengthen access to care for all Virginians by promoting telehealth, mobile integrated healthcare, and healthcare information technology, and by providing safe alternative methods of transportation. Can you put this matrix up now? So this is on the screen here. You see we put the actual matrix that was attached to that letter to the governor. And this matrix had, I believe, 17 total recommendations. You can just scroll down there, Marlene, a little bit. Just remind everyone of what this looked like. And again, you have this document in your meeting binder for today. So all that was sent to the governor on July 28th. Next slide, please. So this was actually, well, the letter was addressed to the governor, but I actually sent it to our Deputy Secretary for Health and Human Resources, Marvin Figueroa, as the gateway into the governor's office, which is just protocol, and we would do that for anything. So I had a phone call with, subsequent phone call with him, and he gave me some feedback that I thought was very helpful, and I shared this with Jim and Dr. Kinzer, and I'm sharing it with everyone now. And the initial feedback that we received was that the recommendations should be further prioritized. And in particular, a way to do that was, it was suggested to focus on those recommendations that really most prominently address health equity issues. And it was suggested further that if the board could prioritize these recommendations, these 17 recommendations down to something in the neighborhood of 5 or 6, that would be a good step towards placing these recommendations in a posture that they would receive attention and adequate discussion within the administration leading up to the next regular session. Which is, if we could do that, we would be doing ourselves a big favor, and that's probably the best possible route for success here. So that's the feedback that I received. I shared that with, as mentioned, I shared that with Jim and Dr. Kinzer. And what they did was they said, well, let us talk, and we're going to send you our ideas for getting this down to 5 or 6 that we could then share with the board for further discussion. So go to the next slide, please. So what we have on the next couple of slides is the prioritized recommendations that came out of the feedback from Jim and Dr. Kinzer. And I'll just, again, read them quickly to you. It would be to appropriate funding to strengthen local health districts, staff, resources, and equipment that are needed to increase vaccination services in the community, including outreach to vulnerable populations. So it's strengthening that public health infrastructure that's needed as part of our vaccine planning and implementation around COVID. Second would be to stockpile emergency mass medical countermeasures. The third would be to appropriate funding for use in targeted communities that have been disproportionately affected due to various types of inequities. Next slide, please. The fourth prioritized recommendation would be to promote telehealth and mobile integrated healthcare through schools and school-based healthcare centers. And the final one would be to increase the provision of subsidized transportation services to medical, pharmacy, and WIC clinic appointments to address barriers to participation that these folks often have just by lack of transportation. Madam Chair, those were the prioritized recommendations that Jim and Dr. Kinzer suggested that we share with the board. If these meet with the board's approval, what I would suggest as a next step would be that I would draft a follow-up letter for you to send to the governor on this subject.
Well, I imagine the next question is questions or conversation. Wendy? It's Wendy.
Okay. Can you clarify for me the item about stockpiling emergency masks, medical equipment, and are we not already doing that?
So, very good question. So basically the context for this, and this was discussed during the subcommittee meetings, is our entire emergency management, emergency response program is entirely federally funded. We have no state money goes to this program. So we are entirely dependent and reliant upon the federal government. So the context for this recommendation and a few other similar recommendations was that the state should provide state money to supplement the federal funds to make us a little more self-reliant in this respect.
And Wendy, specifically on the question of stockpiling things like PPE, we had been asked in the past to prioritize the strategic national stockpile and not have a stockpile here. As you know, that led to some difficulty since the strategic national stockpile was depleted very early on in the pandemic.
Okay. Thank you.
Okay, are there other questions or comments? Alrighty, I'm sorry, Joe, what are we taking a vote here?
I don't know that you need to take a vote. If there's just a general consensus on the next course of action, which would be that I would draft a letter for Dr. Oliver's review, and then for your signature that would go to the governor, that would convey these 5 prioritized recommendations.
Well, how about if we determine consensus by objection? Does anyone object to that course of action? All right, I think that we can receive that as consensus, and we will move forward from there.
May I just add a comment?
You may, but Ms. Hines is going to run the meeting for about 2 minutes until I get back.
Okay.
If that's okay.
Oh, of course. Well, Linda, just an observation, and maybe it's a mea culpa. I reached out to a number of legislators, on both sides of the asking them to be particularly supportive of what we as a board were recommending. And I didn't get much response. I must have sent out to a dozen people who I know personally, some of them for a very long time. And I got 2 responses, one on the House side, one on the Senate side. And I'm sure because the implication of my requests were to spend some money, that it wasn't the most inviting thing in the world for them to be doing in this climate of insufficient funds. But I use this example as a way to urge all the members to reach out to people they know. We've got to find a way to raise the priority level for some of these things that are of such concern to us. And I think obviously we got to go through the governor's office, of course, but we need some help. We need some champions in the legislature. And at the moment, I don't think we have them.
Thank you, Joe. Actually, I wholeheartedly agree with you. I think that it's great that we send this up through the governor's office, but we really need someone to introduce this on the floor.
Jim, are you suggesting we don't have any champions, or we don't have identified champions?
I think the latter. We're, most of the bills that Joe was describing strike me as more negative than positive. I mean, I think they came from Republicans. They were limiting the powers of the commissioner and us, and I mean, that may be an unfair characterization, but I don't think so really. We didn't have, nobody took some of the specific suggestions that came out of our letter to the governor that was sent to many of these legislators, and introduced them as something that they needed to support because the state's public health policymakers were requesting it. I mean, there may be some broad feeling that, yeah, something needs to be done, but we don't have individual champions on the floor of each house, I don't think.
Jim, this is Patricia. I wonder also if it was a matter of timing, given when our letter was ready and the special assembly was happening. So it might not be that we don't have the champions, we just need to identify those champions and figure out the best timing and the best, again, everything comes down to marketing. So how can this be effectively marketed as something that people can pick up and run with?
Yep, no, absolutely right.
I think she's hit the nail on the head, and that is timing. I think it's a very difficult time right now for everybody that we're going through, and we may need to have a little patience and work with the legislators and give them the opportunity, maybe select one that you think might be willing to come out for something like this, but maybe not right now. You know, maybe we need a little patience.
I would offer that the time is now, probably, and what we need to do is think about identifying legislators who would align with us and help us move this forward. I think that's conversations that have to happen after this meeting.
I agree with you, Wendy.
So does anybody have a strategy for that? Because I also agree that the time is now. Because now's when the need is, right? And if we wait till later, we're chasing something that has passed or at least has been put on hold. So I think we need a more concrete strategy for getting those identified supporters.
So could we, when we send the letter with the prioritized items, can we also then CC the speakers, the majority leaders, and then I don't know if the Department of Health has any key legislators that have been, I guess, advocates for the work of the board, the work of the Department of Health, and maybe also send it to them as well.
Madam Chair?
Yes, please, Joe.
I'll just say this. I think the path to success here is to get money included in the governor's budget. I'm not speaking for the legislature, but my observation, I've been watching them for a number of years, and the basic dynamic is this: they all want. It's much easier legislators want the governor to put money in the budget so that the legislators don't have to find the money, right? That's, so, so when we started on this path a couple months ago, you'll recall that I tried to be pretty consistent in the suggestions I've been given to the board, and basically it's, and I'll say it again, it's basically, the best thing that I think that could happen here is if we send this letter to the governor, and it's down to 5 recommendations. We followed our deputy secretary's advice. We have whittled this down to 5. The best possible scenario is that the governor picks up on 1 or 2 or 3 of these, maybe all 5, we don't know, and says, Board of Health, you're absolutely right. Thank you for bringing this to my attention. This is a glaring need. I'm now going to turn around and I'm going to direct the health department, the subject matter experts in the health department, to cost this out for me, to give me the numbers, to let me know how it would work through our established budget process, and then I will find the money in the budget and we will put it in the budget, and it will be in my budget that I present to the General Assembly in December. That's the A+ result here. When we start, the lesser result is, so let's say the governor doesn't put the money in the budget. Then we're left, okay, will the General Assembly move money around to meet this priority, which they can do. But that's a tougher thing, because, so again, I'll just go back to my original suggestion to the board, that what I would recommend that the board focus on is let's focus on the governor, and let's focus on these recommendations, and let's focus on getting the governor hopefully to a place where he accepts 1 or more of these recommendations, then turns it back to the health department for us to cost it out, for us to put the necessary words together to make it work, and then it winds up in the governor's budget as something that he's championing. And the money's already there when the session starts. And then if the General Assembly, all they can do is, if they don't like it, they'll try and take it away, but I would say that's probably unlikely.
Well, thank you for explaining that so clearly. That's very,
Yes.
very helpful, and I think that does give us a path, or it gives us an idea of how we might achieve some success here. Thank you.
Yes, I agree. Thank you, Jeff.
May I, just one follow-up question, if I may?
Indeed.
I can't argue with the logic of what Joe is saying anyway. Does it trump our any advantage we might have in at least talking to some legislators about our concerns? I'm thinking in particular of one senator who has been active in public health for his whole career, and who might be a worthy advocate for us if I could get him to pay attention to it.
Joe?
I think it would be fine to talk to Senator Barker, yeah.
Right. Okay.
Yes, Mary Margaret.
So I think Joe is right in the sense that if something gets in the governor's budget, it's much more likely to stay there. It doesn't require the kind of trade-offs that legislators have to make. But I have a couple of ideas of ways we could proceed. One is that quite properly, he sends the letter to the deputy secretary and it works through the departmental process, and that's what the Virginia Department of Health needs to do. But I don't see anything the matter with us as individual members of the Board of Health writing to the governor directly and telling him that these items are proposed by his appointees, we're all his appointees, to the board, and that we want his we would like to have his particular focus and attention on these items that we've worked to bring forward. And that's an advocacy role that I think would add to going through the proper channels. And then the other thing I think we can do is talk as members of the Board of Health to the legislators we know and say how clear it has been that public health infrastructure is underfunded, that money went down in the recession and it has never come back up the way that it should. We're too heavily reliant on federal funds, and we need to use this as a clarion call to put more state money into public health and get them thinking about it, whether it's an individual item that they're interested in or not, but at least have it in their consciousness that public health infrastructure is woefully underfunded.
Agreed. Any other comment?
Yes, so what are our next steps here?
Joe, you want to just lay that out?
Sure.
And the official steps?
Sure, so what I would say would be the next steps are that on my end, I will be drafting a letter for you to send to the governor, Faye. And then individual board members, as they see fit, will be reaching out individually to the governor and or to individual legislators.
And as soon as we all get a copy of that letter, then we will start contacting our individual folks. I think that's what I want to make sure we're clear.
Yeah, absolutely. Yes.
Okay. All righty. All right, is there anything else about this item? All right, then we will now go on to the board meeting schedule. And after we do that, Anna, I will let you speak to your issue, if you don't mind.
Okay, thank you.
Okay, so board meeting schedule first. All right, so these are our proposed meeting dates for 2021. Is everybody okay with maintaining? Joe, why did we move to December 10th instead of December 9th on a Thursday? Just out of curiosity.
So assuming, or with the idea that we might be meeting in person, there was not, the room that we use is not available. So there was not the space on a Thursday, any Thursday in December.
Oh, okay. All right. I was just curious. Does anyone have any objection to this list of proposed meeting dates? Well, actually, before we do that, can we have a motion to approve those?
Which date in March are we motioning to approve?
So what I want to do first is get a, oh, well, that's true. I can't get a motion until we get that. Why do you have 2 days for March? Sorry.
Both days were available. It was the only quarter where there was some flexibility, so I wasn't sure which date would be better for the board, so we wanted to provide you with the options.
Madam Chairman,
Mary,
I wonder when the General Assembly session concludes next year. Should be near the end of February, but I don't have the dates in front of me.
It would be the end of February, the last Saturday in February.
No.
Which is it's the 28th, I guess.
It would not be.
Yeah.
It would not be in March.
Close to it.
Yep. All right. Does anyone have any preference for either of those dates in March? Or preference against one of them?
I think it makes more sense to give ourselves some time between the end of the session and our meeting to try to get a little bit more awareness of everything that's transpired that would affect us.
So March the 18th.
Okay.
So the proposed meeting dates for 2021 would be Thursday, March 18th, Thursday, June 10th, Thursday, September 2nd, and Friday, December 10th. Before we have further discussion, can we have a motion to approve? From you.
This is Linda Hines, I move to approve the proposed meeting dates.
Okay, and a second?
I second.
Okay, so now, is there any further discussion about those meeting dates?
I guess we have
All right.
another point. Is that right, for Friday, December 10th?
Well, not as it stands right now, Catherine, because we could not get the room for Thursday. Is that problematic for you?
Oh, I would prefer another week. I mean, it's not the worst.
That's assuming we could do it in person.
Yeah.
So, Madam Chair?
Yes, sir?
So the Friday, December 10th date was selected under the assumption that we would have an in-person meeting of the board next December as opposed to a virtual meeting. But, so that's why. So, but of course, if it turns out as we get through next year that an in-person meeting still would not be possible, that we could always revisit that meeting date. If we were gonna do a virtual meeting, then obviously we could do it any time in December that it was convenient for the board members.
Well, dear God, in heaven, it puts out, I certainly hope we're meeting in person.
So do I.
Me too.
No.
Okay.
All right. So let's go ahead and take a vote on this. All those in favor of that current list signify by saying aye.
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 All those opposed? Okay, those are our proposed meeting dates. Now, under other business, Anna, could you let us know what you propose for us?
Oh, okay. Yeah. Well, like the board member Jim Schuler, and I also concerned how student return back to campus affect, the COVID-19 situation in the communities. So in the summers, and I call the Dr. Nancy Welch, which is directors and for the Chesapeake Health Department, and to discuss this issue. And from that, Dr. Welch let's get together with the people because I suggest wastewater surveillance. So she suggests let's have a meeting with the people from Hampton Roads Center District, and also a couple of the staff members from the VDH, divisions of water and wastewater service of the VDH in Richmond. And so we did have a meeting over the summer, and from the meeting we got ideas to form a working group. And so which means that what the name for the working group is the Hampton Roads Wastewater Surveillance Working Group. So idea is we want to explore whether we can use wastewater surveillance for COVID-19 to look at our spatial temporary trend, and also identify our hotspots, and also whether we can use wastewater surveillance as an early warning tool. And I believe the CDC's already start funding the states to build a network for this type of work. So this work, I co-chair this working group, and over the summer, we already got all the people together. Right now, we have 17 members represented from BDH, HRSD, and also academia, Virginia Tech, and ODU. And so we have done quite a bit of work. And in fact, HRSD already started monitoring the COVID-19 in wastewater since March. And you may know, COVID or virus usually present in the stool probably at least 4 to 7 days before in the clinical cases. And so, so we have done quite a bit of work. And I suggest that, this working group to give a presentation to the board because it had lots of applications. And so at the give a print at the next meetings. So if the entire boards are open, to get more information about that. I do know VDH doesn't have a central program to do this type of work. It all depends, up to the local office. However, VDH is applying for funds from CARES and also CDC. So to build a network and also funding some pilot program. And so I found out there's a lot of potential applications of this wastewater surveillance. And I would like to share a lot of data and also knowledge and the recommendation from the working group. And the presentation probably only lasts probably about 50 minutes or so.
Okay. So I think what we need here is just a consensus that we'll get Dr. Jang's working group on the next agenda for a presentation. Is that correct, Joe, or do we need a vote?
That'll be fine, just a general consensus. We'll reflect that in the minutes and we'll make sure
It's needed.
Oh, sorry. Yes, just general consensus is fine. We'll reflect it in the minutes for today and we'll make sure it's included in planning for the next meeting.
Well, that sounds great. Well, we'll have a representative from VDH and also a representative from HRSD, include myself. So we have 3 members. We'll give about 15 minutes presentation, on this topic about wastewater surveillance for COVID-19.
Thank you, Dr. Jang. Is there any objection to such a presentation? Okay, then I think that's consensus. And our last item is any other business. Is there anybody else who wants to tell us anything else?
I have one, Faye.
Yep. All right, Jim.
I had the presentation of a problem that we face to me and a solution. But getting from point A to point B has been difficult. So far, impossible. The problem was pointed out to me by a citizen from the town of Vienna, Virginia, Northern Virginia, which has over 100 restaurants in it. And they're going broke daily. Many of them are small, not franchised, individual establishments that don't have a lot of resources but are important to the community, both because of simply what they are and the economic strength that they offer a community in the form of taxes paid. Many of them have reopened. Few customers are coming because many people, maybe like you and I, don't want to come because we don't think it's safe yet, particularly because of the way the air is circulated and the risk of transmission. I asked EDH if they could offer some suggestions, and they sent me to the housing authority, the department, that offered, frankly, nothing that was helpful. And it's one of these crazy circumstances that it sort of falls between the cracks. Who's in charge? Where do we find the money to do a solution which exists, that we might install someplace, prove its viability, and find a way inexpensively to get restaurants to install it so they can reopen and attract customers again. Unbelievable, tens of thousands of people around the state work in restaurants who are now laid off. So what do? The answer, I don't know. I'm still looking for somebody to fund the thing. Obviously, BDH is the regulator. We're not in the business of providing capital for such activities. The housing department really isn't either. I haven't found the right person to go to get a relatively modest amount of funding to implement a model that might serve as a tool to permit the reopening of literally thousands of restaurants around the state. But here we are. All suggestions welcomed. I'm still looking for a solution and looking for some money that might actually get it funded. It's just one of those things that doesn't fit into a nice silo about what somebody ought to be doing to make it happen.
Jim, do you think you might consider sending your fellow board members your idea in writing? I have access to it, but not everyone does, and perhaps we could better brainstorm some opportunities if we had some time to consider your ideas.
I'm always concerned about how many people can we circulate these things to. I guess if I send it to Joe can send it out, or you can send it out.
Joe, tell me the best way to make this happen. I think you.
Madam Chair,
I think I'm right that you could send it out, but we couldn't respond to all.
Madam Chair, I'll be happy to. Jim, if you can resend it to me, please, and I will then resend it to the board. Per our discussion of the meeting, and I will just include my customary end to the letter. If you must reply to this, please do not reply all.
Right.
Yes, sure, that's fine. Good.
All right.
Jim?
Yeah.
I'm thinking you've talked to these folks about the PPP loan and then the Small Business Administration EIDL loan.
Yeah, the problem is the skill level and the familiarity with these small businesses. I mean, they can't afford to hire a lawyer or a consultant to go to a bank and fill out a lengthy form. I mean, those things are ideally suited. Let me that you're in a perfect world, yes.
Yeah.
But most of these shops are, they just don't have the financial resources to do this individually. We got to figure out a way to do it in a very expensively. I'm sorry, very inexpensive. If it's going to happen at scale.
Well, I know that SBA did greatly simplify that EIDL loan process. And I know in Richmond, there's some independent restaurants that have sort of banded together to kind of explore resources available as a group. So that could be an option. And then there's also Underground Kitchen. I'll reply to you about that, but I think they're helping. Yeah.
That'd be great.
Okay.
All right. Anything else?
Madam Chairman?
Yes, ma'am, Ms. Whipple.
I'd just like to thank you for allowing the Polly Rabel from VHHA in collaboration with BDH to tell you about the Unite Virginia potential project. If anyone felt inclined to support it with the governor, why that might be a good thing.
We certainly are happy to hear from her, Mary Margaret, and I will do that. Anybody else?
Hey, it's Gary.
Hi, Gary.
Hey, just really briefly, Just wanted to publicly acknowledge, I know there were several comments earlier about the work of VDH during the COVID pandemic. In my job here in Waynesboro, certainly I'm knee deep in the middle of it as the emergency manager, and work very closely with the staff at the Central Shenandoah Health District, and all of them have been exceptional. And I'm a little cautious about identifying any specific individuals, but I do want to just acknowledge Dr. Laura Cornegie, the health director, and Hillary Crone, the emergency manager, have been exceptional in meeting the needs of our community and our region, along with the staff in the central office. So a huge thank you to VDH for all the support they've given us. We certainly could not have done all we've done without them. And just briefly with regards to Bruce Edwards, I don't know how many folks are aware that Bruce lost his daughter 2 weeks before he died. His 43-year-old daughter, Patricia, died on the 7th of August, and then he passed away on the 22nd. So his family is experiencing two significant losses, so if you just keep them in your thoughts and prayers.
Thank you, Gary. I can't even imagine. All right, anybody else? Well, as always, you guys are the best board ever. I hope you find some relaxation in the rest of this day, and with that, we are adjourned.
Thank you.
Thank you, Faye.
Thank you.
Thank you, Faye.
Thank you, Faye. Thank you to the Board of Health. Thank you.
Bye, all.
Thank you, everyone.
Mhm.